then we must know the management and details of the acid-base disorder. We already learned in the previous class that acid-base balance is affected in many poisoning. Normal arterial blood pH is 7.4 and blood pH less than 6.8 and more than 7.8 carry a profound risk of the death. Metabolic acidosis less than bicarbonate level 24 is said to be metabolic acidosis. Alkalosis when serum bicarbonate level is more than 28. So we remember 24, 28, 36 of the serum partial pressure of the CO2 less than 36, that is suggestive of respiratory alkalosis. Then partial pressure of the CO2 more than 44 is suggestive of respiratory acidosis. Increasing metabolic acidosis with normal partial pressure of oxygen are suggestive of toxin or carbon monoxide poisoning, methemoglobinemia, cyanide or hydrogen sulfide. So, metabolic acidosis is one of the commonest presentation in case of the poisoning. So, the metabolic acidosis needs a special attention. For the treatment of metabolic acidosis, if the metabolic acidosis persists even after the correction of the hypoxia, adequate fluid resuscitation should be considered along with the IV administration of the sodium carbonate. The drug of choice is the sodium bicarbonate. It is widely considered to be the best antidote for the acidosis of almost any etiology. We already talked that in adults the initial dose of 50 millimole may be given and repeated as necessary, and the ABG monitoring should be done. In children, use 8.4 sodium bicarbonate diluted in equal volume of the 5% glucose. Since 4.2% and 8.4% sodium bicarbonates are irritant to the vein and can cause local necrosis in cases of extravasation, administration of central venous line is recommended and the sodium bicarbonate shall be given through the central venous line. Monitor electrolytes since there is a risk of hypokalemia and possibly hypernatremia. Then coming to the convulsions and the seizures. There are several drugs and poisons which causes convulsions. Improper treatment or mismanagement can lead to the status epilepticus, which is life-threatening condition. Toxic convulsions may be categorized into three categories. One is those that respond to the standard anticonvulsant therapy like those of the typical benzodiazepines. Second category is those that either require a specific antidote to control the seizure activity or that don't respond consistently to the standard anticonvulsant treatment such as isoniazid-induced seizures. Isoniazid-induced seizures require pyridoxine administration. And third category can be those that may appear to respond to initial treatment with cessation of tonic-clonic activity but which leave the patient exposed to underlying unidentified toxins or to continued electrical seizure activity in the brain such as seen in case of carbon monoxide and hypoglycemia. So this is the list of the drugs that can cause the convulsions and seizures in the patient. During the toxicity phase, this is the following drugs: cocaine, anticholinergic, cyanides, organophosphate, camphor, strychnine, heavy metal. They all cause toxicity during their initial phase. And the barbiturates, ethanol, benzodiazepines, methaqualone, opiates cause the toxicity during their withdrawal phase and produce convulsion in the patients. Now what shall be done to treat the seizure activity? First and foremost is the administration of the oxygen by the nasal cannula or the mask is good for the control of seizure. Then the position of the patient's head for optimal airway patency shall be maintained. Establish the IV line. Begin the drug therapy with benzodiazepines. Usually, benzodiazepines are effective to control the convulsions, which includes the diazepam 10 to 20 mg in adults and 0.1 to 0.3 mg per kg in children. Other benzodiazepines like lorazepam 4 mg in adult and 0.1 mg per kg in children, or midazolam 5 to 10 mg in adults, 0.05 to 0.15 mg per kg in children. If convulsions are unresponsive to the benzodiazepine, then the second line of therapy is the phenobarbital sodium, that is given at a dose of 10 mg per kg at a maximum rate of 100 mg per minute. If convulsion still persists, consider the need for referral to the ICU, general anesthesia, intubation and ventilation. There may continue to be epileptic form of activity, and measure to monitor and control of this is necessary. Use of cerebral monitoring is therefore recommended, as we saw in case of the hypoglycemia and cases of the carbon monoxide poisoning. Thiopentane sodium is the preferred anti-epileptic for the status epilepticus not responding to all the above measures. Then coming to about the agitations. Several drugs and poisons are associated with the increased aggression, which may sometimes progress to the psychosis and violent behavior. This is especially likely if there are other predisposing factors such as existing mental disorders, hypoglycemia, hypoxia, head injury, and even amnesia or anemia and the vitamin deficiencies. Delirium is the term which is often used to denote such acute psychotic episodes, and it's characterized by disorientation, irrational fears, hyperexcitability, hallucinations and violence. Dementia, that is a more gradual decline in the mental processes, mainly resulting in confusion and memory loss. And though it is often organic in nature due to degenerative disease, there are some drugs which can cause this, especially on chronic exposures. Elderly patients are more vulnerable to it. Dementia due to the drugs is usually reversible. This is the list of the drug associated with the agitation and the psychotic behavior. The drugs that produces during their toxic phase are the benzodiazepines, cannabis, ethanol, hallucinogens, cocaine, amphetamine, corticosteroids, anticholinergics, dhatura, antidepressants, and digitalis. Drugs that produce agitation and psychosis during withdrawal are the barbiturates, ethanol, and opiates. Adults, for the treatment purpose, adults can be sedated with the initial dose of the benzodiazepine, that is oral or IV diazepam at a dose of the 0.1 to 0.3 mg per kg. Further, boluses shall be given IV, may be administered if the patient remains severely agitated 10 to 15 minutes after the initial bolus, provided there is no impairment of the respiratory functions. If agitation persists despite the above measures, then consider oral or parenteral haloperidol initially in elderly, and in patient with a drug-induced hypothermia, serotonin syndrome or severe agitation may need high doses of the haloperidol totaling more than 1 mg per kg over 30 to 60 minutes. These patients need urgent referral to the critical care centers. In children, it is better to manage agitation without sedation and exclude other causes like hypoxia, infection, hypoglycemia, and raised intracranial pressure. Consider nursing those patients in the dark and quiet environment with a close relative present. Pharmacological management of the agitation in children must be supervised by the staff experienced in pediatric airway management and sedation. If required, midazolam is the most appropriate drug for managing agitation in children and young people. This may be delivered orally buccal mucosa with a dose of 0.2 to 3 mg per kg to a maximum dose of 10 mg, and intravenously in the dose of 0.05 to 1 mg per kg, 0.1 mg, not 1 mg, to a maximum dose of 10 mg. Intravenous lorazepam shall be given in the dose of 0.01 mg per kg is an alternative for the midazolam. This may be delivered buccally in the dose of 0.2 to 0.3 mg per kg to a maximum of 10 mg, or intravenously in a dose of 0.05 to 0.1 mg per kg to a maximum dose of 10 mg. Intravenous lorazepam in the dose of 0.01 mg is an alternative to the midazolam. Repeated doses may be given if necessary. There is particular risk of paradoxical increased agitation in the young children. Now, the different movement disorders associated with the poisonings. Exposure to the several drugs and toxins can result in wide variety of movement disorders ranging from full-blown Parkinson's disease to isolated tremors. Parkinsonism, the most frequent culprits are phenothiazines and major tranquilizers. Though there are several other which has been implicated, symptoms of Parkinsonism usually appear in first 3 months of the exposure and may be indistinguishable from the idiopathic Parkinson's disease. Motor neuron disease, the various types of the toxins can induce the motor neuron disease like those seen in the letharism produced by the chickling pea, that is the Lathyrus sativus seeds that contains the toxin BOA, BOA, beta and oxalyl amino L-alanine. Then the myopathies may be another disorder. That drug-induced myopathy may result from the direct toxic effect, which may be local due to the injection of the drug into the muscle, or more diffuse when the drug is taken systematically. Repeated injections of the antibiotics or drug of addiction often lead to severe muscle fibrosis and contractures, myositis fibrosa, myositis ossificans. Clofibrate aminocaproic acid can cause acute necrotizing myopathy with myoglobinuria and renal failure. Other drugs that can induce toxic myopathies include succinylcholine, halothane, corticosteroids, chloroquine, D-penicillamine, alcohol, phenytoin, and others. Environmental causes may include the exposure to the silica, certain types of food like adulterated rapeseed oil, and medical devices such as silicone implant. They all can cause different types of myopathies. Then the akathisias, dystonic chorea, and tardive dyskinesia can be produced by the tricyclic antidepressants, monoamine oxidase inhibitors, MAO inhibitors, fluoxetine, lithium, buspirone, levodopa are the principal cause of drug-induced akathisia. This is characterized by extreme restlessness with constant movement and the muscular quivering. Dystonia usually manifests as the facial grimacing and torticollis and is mainly associated with phenothiazines, butyrophens, metoclopramide, tricyclic antidepressant, phenytoin, chloroquine. Chorea, which causes involuntary writhing movements like a typical movement of limbs, is most commonly seen with anticonvulsants, especially phenytoin, anabolic steroids, amphetamines, levodopa, and sometimes with cimetidine, ethanol, and cocaines. Phenothiazines and metoclopramide are most often the culprit in drug-induced tardive dyskinesia, which is characterized by stereotyped slow rhythmic movements. Then the patients may present with myasthenia crisis. This refers to the sudden onset of severe muscular weakness and may be precipitated by aminoglycosides, polymyxin, penicillamine, tetracycline, quinidine, lidocaine, quinine, curare, succinylcholine, procainamide, and some opiates. Then the fasciculations are the contraction of the muscle fiber within an individual motor unit and appears as a twitching of the affected muscles. The tremor may also be produced by the different types of the drugs, and depending upon the types of the tremor, different causes are there. The different tremors may be the resting tremor, postural tremors, kinetic tremor, choroid type of tremors, dystonic tremors. And the treatment of most of these movement disorder, that is the Parkinson's, motor neuron disease, myopathies, akathisias, dystonic chorias, tardive dyskinesia, myasthenia gravis, fasciculation and tremors are basically the removal of the drug that is causing the effect. So, withdrawal of the incriminating agent commonly results in the recovery of the patients. And the symptoms depend on the dose and duration of the drug. The usual measures taken for the management of the respective drug overdose will be discussed in the respective classes when we will be dealing with separate toxins. Then we should correct for the electrolyte disturbances. Then that includes the hyperkalemia. So potassium level more than 5.5 milliequivalent per liter. The causes include digitalis, beta antagonists, potassium sparing diuretics, NSAIDs, chloride, heparin, succinylcholine, and drug producing acidosis. The manifestations that are presented are abdominal pain, diarrhea, myalgia, and weakness. ECG changes that will show the tall peak T wave, ST segment depression, prolonged PR interval, and QRS prolongation. In severe cases, there may be ventricular fibrillation. For the treatment of hyperkalemia, we shall use glucose, insulin infusion, sodium bicarbonate, and calcium gluconate. Hemodialysis and exchange resins may also be required. Hypokalemia is said when the potassium level is less than 3.5 milliequivalent. The causes for the hypokalemia include beta agonists, theophylline, insulin, chloroquine, caffeine, dextrose, loop diuretics, thiazide diuretics, oral hypoglycemics, salicylates, and various other drugs. The manifestations in case of the hypokalemia are the muscle weakness and paralytic ileus. On ECG, there will be flat or inverted T waves with prominent U waves and ST segment depression. In severe cases, there is AV block and ventricular fibrillation. And the management for the hypokalemia includes oral or IV potassium infusion. Hypernatremia is said when the sodium level is more than 150 milliequivalent per liter. The causes includes colchicine, lithium, profexin, rifampicin, phenytoin, alcohol, and various other drugs. The treatment for hypernatremia is the water restriction with or without loop diuretics. Then hyponatremia is said when sodium level is less than 130 milliequivalent per liter. The causes include carbamazepine, chlorpropamide, NSAIDs, amitriptyline, bigonides, ACE inhibitors, lithium, oxytocin, and excessive water intake. The treatment is done by the hypertonic saline solution. Then hypocalcemia is said then when the calcium level is less than 4 milliequivalent per liter. Causes for hypocalcemia are the hydrogen fluoride, oxalates, aminoglycosides, ethanol, phenobarbital, phenytoin, theophylline, and ethylene glycol. Treatment for the hypocalcemia shall be the calcium gluconate given in 10% solution 10 ml at a time slowly. Drug-induced hypercalcemia is very uncommon. So with this, we shall all know look for the different electrolyte imbalances and manage them accordingly. Then finally, other measures that may be applied under the evolution of the patient that may be remembered with the FGHIJKLMNOP, that F for fluid management, also maybe the Fahrenheit, note the temperature, hyper and hypothermia, G for get vital sign, G for gastric lavage, H for head to toe examination, I for imaging, radio-opaque poisons may be seen on the imaging, and then intervention, I for inspect back, IJ for the jaundice, attend for the, if there is jaundice, then look for the poisons, hepatotoxic poisons, then the kidney failure, K for, L for laboratory test, M for magnesium hydroxide, that is cathartics that shall be given, and N for the narcosis, and O for observe, O for the oxygen can also be there, and then P for the pulse. So this mnemonic got enlarged to A to P, A, B, C, D, E, F, G to up to P. So this may be used to remember that, so that you don't forget when the patient comes in your clinic or in your hospital for the examination or the patient with the poisoning. And then shift the patient to the proper environment after the patient is stabilized. Usually the dark and quiet room are used for the further care of the patient. Especially the photophobia are observed in case of datura and methyl alcohol poisoning, and in case of strychnine poisoning, the patient is hyperexcitable to the light and the sound. Most patients, whether conscious or unconscious, would recover by these measures alone. These methods, where all these ABC due to E measures, were first used by the Scandinavian physician in mid-1940s in barbiturate poisoning, with dramatic success. After the World War II, the incidence of suicide by the consumption of barbiturates increased tremendously. The history of development of this ABCD after the barbiturate poisoning, if the World War II, is very interesting and must be read. In the 1940s, this drug was commonly used as a suicide measures, and a lot of deaths were happening due to the barbiturate poisoning, and the not very developed system of the management of toxicity and poison was there. So at that time, various scientists, through the observation and through the different procedures, they devised this ABCD measures and found that this is playing a very important role in the improvement of the patient. So looking after the ABCD is now also known as Scandinavian method of treatment, and particularly in case of barbiturate poisoning. So with this, we now today finishes the immediate resuscitive measure. From tomorrow, we will learn how to remove unabsorbed poisons from the body and later the absorbed poison from the body. With this, thank you so much for your patient listening. Best wishes.